urgent, we can operate on an aneurysm if the aneurysm needs to be clipped anyway. Suppose they have a big intracerebral hematoma, so we're going to be there, we're going to be taking the hematoma out. We can clip the aneurysm based on the CTA now without catheter angiogram. Now that we're treating the majority of these with endovascular coiling, that's less and less the case. But during the period where CTA was good and we weren't doing as much endovascular therapy, we actually treated a lot of aneurysms based on CT angiogram alone without even getting a catheter angiogram, because they're just that good. You can see the aneurysm, and you need to get to the OR, so we just took them straight from CTA. MRA is a little bit more of a third line for us now, that if the CTA is negative and the patient is going to get an MRI anyway, so suppose we started with a CT, we get a CTA, and it's negative, and so we know we're going to get an MRI because we want to look for a parenchymal lesion, for example, then we may go ahead and get an MR angiogram while we're down there. It's just to have one more study to look. And then if that's negative, the only thing left is a catheter angiogram. So we use it sometimes as another option to look before a catheter angiogram. Some centers, Ted, you maybe want to speak to this, maybe you like their MRAs better than their CTAs and use it preferentially, but I think here we find the CTAs better. What do you think?
Again, there are individualized cases that speak to the contrary, but in general, MRA is a screening examination, and CTA, because it has higher spatial resolution, it's better for evaluating the aneurysm and adjacent blood vessels. So CTA is primarily the first line to evaluate an aneurysm. The downside is that there's radiation exposure, which you don't have with MRA. And so if you have a patient with repeated CTAs or CT perfusion studies, the radiation dose can significantly accumulate. There's also an issue with CTA with artifacts. So a patient has a coronary aneurysm, I'm going to show this. Patient has an aneurysm clip, you're not going to see very much. It amazes me that there are some physicians out in practice who will get a CTA of the head to evaluate the status of a clipped aneurysm. And it's because of the beam hardening artifact from the surgical clip, you're not going to see the aneurysm.
And I'm glad you mentioned the screening too, because if you're screening for like familial aneurysms or aneurysms in somebody with polycystic kidney disease, the MR angiogram is a simpler or better study. It may not be quite as good a resolution as a CTA, but it doesn't require radiation and it doesn't require contrast. You can do an MR angiogram with or without gadolinium. It's a little bit better with gadolinium, but you can do an MR angiogram without gadolinium. So if you have concerns about a patient's renal function, you can still get an MR angiogram. So screening PKD patients, for example, we like MR angiogram much better. And even though it's not as good, you can still identify aneurysms as small as 2 millimeters, and definitely greater than 2 millimeters you can usually find on an MR angiogram. And you have to ask yourself, if you're screening, do you really want to find an aneurysm that's smaller than 2 millimeters? Because they're really hard to treat. We usually can't treat them when they're smaller than 2 millimeters, so you're almost better off not even knowing they're there. So the MRA is a great screening tool because it finds aneurysms that are big enough to worry about and treat. All right, any other questions?
You talked a little bit about traumatic subarachnoid hemorrhage. Can you just comment briefly on sort of biology or the physiology of why we see vasospasm after aneurysmal subarachnoid hemorrhage versus the other types like traumatic?
Yeah, that's a great question. And it doesn't have anything to do with the mechanism or the pathophysiology or a difference in the blood. It's all about location and quantity. So you can have vasospasm after traumatic subarachnoid hemorrhage if you have enough subarachnoid hemorrhage in the basal cisterns or sylvian fissures. And so There's nothing different about it except for the quantity and the location. And so if you have a patient, it's just that most traumatic subarachnoid hemorrhages are small convexity subarachnoid hemorrhage. And so we don't see vasospasm in that setting. But if you have a big traumatic subarachnoid hemorrhage, like a patient with a basilar skull fracture, or just a really bad injury, these are usually not in isolation. These are usually patients with really severe injuries that have a big enough subarachnoid hemorrhage to fill the basal cisterns or fill a sylvian fissure, and that patient can definitely develop vasospasm. We have seen it here for sure. And we've seen patients develop delayed focal neurologic deficits from vasospasm from traumatic subarachnoid hemorrhage. We've seen hemiparesis and hemiplegia from MCA vasospasm with a lot of subarachnoid hemorrhage and sylvian fissure. And we've seen general alteration in consciousness from vasospasm and anterior cerebral artery spasm and posterior circulation spasm. And so if we have a patient with a lot of subarachnoid hemorrhage after trauma, and especially if it's thick in the basal cisterns and sylvian fissures, we should be doing daily TCDs on those patients. And we should be thinking about vasospasm and watching for neurologic changes. Obviously, they're getting Q1-hour neurochecks anyway. And so that's a really good question. It's all about location and quantity. Somebody else have a question?
Why don't we take a break now?
Okay.
Go ahead.
All right, thanks.
Thanks, sir.